place? I said, well, I went to a meeting in Ljubljana, in Slovenia, as I'll mention. We did a European review of social determinants and the health divide. And at this meeting in Ljubljana, countries from right across Europe were gathered to talk about what they've been doing on social determinants of health and health equity. It was really exciting. And then I flew that evening. I'll tell you the slightly embarrassing bit. I was walking from the hotel to the meeting, and I was wheeling my wheelie bag, and one of the Slovenians said, "Why you got your bag with you?" I said, "Because I'm flying to Tokyo this evening." He said, "Aren't you a bit old for that kind of thing?" And the World Medical Association and the Japanese Medical Association were having a meeting on universal health coverage. And I said, "I don't want to come. It's very important, but that's not what I do." "No, we want you to kick it off and talk about social determinants of health." And then, just in case I wasn't convinced, they said, "And Her Imperial Highness, the Crown Princess, wants to come to your lecture," which she did. We had tea together. And afterwards, one of the Japanese Medical Association people came running up to me and said, "The Imperial Household wants your contact details." "Why?" "Because Her Imperial Highness wants you to be her teacher." I thought, that never happened to me in Britain. And then I went from there to Hong Kong, and there were all these demonstrations. I thought just because I arrived in Hong Kong, there were all these demonstrations. But I convinced the Vice Chancellor of the Chinese University of Hong Kong to set up an Institute of Health Equity, which we would support from UCL. So I said to my friend, "It's all good. As long as I don't read the newspaper, it's all good." And I said, when I came into this room, the energy I could feel in this room was terrific. It's all good. We're surrounded by terrible politicians everywhere. But people who are actually at the front line are motivated, energetic. I get asked the question, is anyone listening to you? And the evidence-based answer is yes. Yes, they are. No question about it. That's why I'm upbeat pretty well all the time, provided I could wean myself away from the newspaper. Now, it's not a totally unrelieved picture. The first line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick. And we ain't doing so well in terms of conditions that make people sick. When we reported, don't scratch, you get feedback. When we reported this first a couple of years ago, there was quite a bit of pushback. Life expectancy, we've taken it back to 1980 to 82, but in fact, if I took it back to 1920, the end of the First World War, life expectancy just kept going up 1 year every 4 years. Fantastic, for 90 years. From 1921 to 2011, 90 years, life expectancy improved 1 year every 4 years. And it relates to what you and I were talking about, decline in infant mortality and other things. And then in 2010-11, it ground to a halt. You can imagine there was pushback from the government because people said, "Oh, is this austerity?" You might say that. I couldn't possibly comment. Well, it could be. We should look at it. The government said, no, it couldn't possibly be austerity. It must be the flu or a cold winter, or an artifact, or we've reached peak life expectancy, or anything but what we did. Well, we haven't reached peak life expectancy. This is European countries, 2 5-year periods, 2006 to 2010. You notice my high-tech pointer. 2006 to 2010, and the dark ones 2011 to 2015. And indeed, this is women, there was a slowdown in most countries in the latter period, which would be consistent with austerity, with the economic problems, the crash, and then policies of austerity. But we're bottom. We're worst. So it's not that we've reached peak, because other countries are still improving, and many of which had better life expectancy than we did. And when we look at change in life expectancy, somewhat later years, up to 2015, 17, in England, it really stopped improving. In Northern Ireland, going down for men. In Scotland, going down for men and women. In Wales, going down for men and women. Now, my general proposition is that health tells us something really important about the nature of society. Nobody really cares about a few weeks' decline in life expectancy. It's not a meaningful statistic. But it's an indicator of health, because underlying these few weeks' change in life expectancy is a lot of difference in healthy life expectancy and morbidity and suffering and disability and the like. So the fact that life expectancy was improving year on year, decade on decade, meant that society was improving in the way people could lead their lives. The fact that it stopped increasing, stopped improving, and inequalities were increasing, a slightly technical measure, the slope index of inequality is a measure of inequality across the gradient, and you can see it's tending upwards. Means that inequalities in the conditions in which people lead their lives are increasing. That raises the question, if the government was a bit defensive and said it couldn't be anything we did, a former Prime Minister, I'll never forget what's his name, was interviewed this week, saying his only regret was we didn't do austerity faster. Kill more people. My only regret is we didn't kill more people. It's known as compassionate conservatism. I'm not party political. Perish the thought that I would ever make a political comment. I just look at the evidence. So I'm not pro any particular party, but New Labour did have a strategy to reduce health inequalities. Any evidence that it worked? Colleagues at the University of Liverpool, that's quite close to here, isn't it? But anyway, looked at the difference in life expectancy between local authorities classified by degree of deprivation. So it's the difference between the poorest 20% and the rest. And in the period 1983 to 2003, the gap in life expectancy between the poorest 20% and the rest was increasing. Then New Labour was elected, took a while to articulate a strategy and start doing things. And in the period from 2004 to 2012, the gap between the poorest 20% and the rest decreased. Then we had a new government, ditched the previous strategy. Took a while for things to happen, and the gap started increasing again. Correlation is not causation. This is not proof, but it is consistent with the notion that the magnitude of health inequalities that we see is not fixed, and government action can make a difference. And that action, the evidence shows, does not have to be at national level. It can be at local level, which is why you're gathered here. Does the USA represent the future? Life expectancy declined 2 years in a row. In fact, it's now 3 years in a row. Big increase in unintentional injuries, and unintentional injuries include accidental drug overdose. As part of my feeling upbeat, I was in, what day is it? Where am I? Thursday. Monday last week, I was in Los Angeles. We were setting up a health equity network in the Americas because, as I'll say in a moment, we're about to publish the report of the Commission of the Pan American Health Organization on equity and health inequalities in the Americas, which I chaired. And so I was in LA, we were setting up, and jet lagged and lying in bed, sort of dozing, reading. 2:30 in the morning, I get a phone call from the BBC. Would I go on PM, on Radio 4? So it's 2:30 in the morning. Oh, I'm terribly sorry for waking you. Would you go on PM? What's it about? Public Health England had published a report on the overuse of 5 drugs. A quarter of the adult population were using antidepressants or opioids, benzodiazepine, a couple of others, but for those 3 linked to deprivation. The more deprived the area, the higher the use. So we're starting to head down that road. We don't have the same epidemic of opioid poisonings that the US does, but it's starting to increase. And we're now seeing an increase in mortality at younger ages. That slowdown in life expectancy that I showed you was primarily because of an increase in mortality at older ages. But now we're starting to see the increase at younger ages. And if we asked, what's happened to life expectancy in the US? This is life expectancy at age 50 by birth cohort. So people who were born in 1920 will be 50 in 1970. People who were born in 1950 will be 50 in 2000. By birth cohort and income decile. So for people age 50, born in 1920, the lower the income, the lower the life expectancy. The higher the income, the higher the life expectancy. It's a gradient. Over the next 30 years, the poorest 10% got almost no improvement in life expectancy. The next 10% got some improvement, and so on. The richer you were, the higher your income, the bigger the increase in life expectancy. So the gradient got dramatically steeper. That's men. There was such good feeling in the room when I walked in. I hate to ruin it, but just remember how you were feeling before I show you the next slide. That's men. Oh my goodness. Life expectancy is going down at age 50 for women in the bottom 10%. It's going down in the next 10% and the next 10%. For the bottom 30% of the income distribution, life expectancy for women is going down, and the inequalities are getting dramatically bigger. And that orange nightmare in the White House is saying, well, the country's the best it's ever been. Does he know? Does he care? What's going on? This is terrible. This is terrible. It means something's going very wrong in society to have this slowdown in life expectancy in the US, a fall 3 years in a row, and a huge increase in inequalities. And when we look at the US, when I ask, are we going down that route? This is from UNICEF report card 14, neonatal mortality, suicide for 0 to 19 years old, mental health at 11 to 15, drunkenness 11 to 15, fertility 15 to 19. And the 3 priorities that you decided on earlier today, these indicators of well-being in young people relate to all of them. UK, yeah, sort of middle of the road, not terrific, not terrible. And there's the US, way, way down there. And it's part of my general proposition that the mind is an important gateway. I think air pollution is very important, so the mind's not the only gateway, but the mind is an important gateway by which social determinants affect ill health. Effects on mental illness and psychosocial pathways to physical illness. Behaviors, obviously, what most people think about is very downstream. Oh, we've got to do something about non-communicable disease that will get people to give up smoking. Part of my feeling upbeat, by the way, when we produced our report of the WHO Commission on Social Determinants of Health in 2008, commissioned by the Director General of WHO, and WHO Geneva did nothing. Did nothing. On Boxing Day, I got a direct message on Twitter, DM, from Dr. Tedros, the Director General of WHO, saying, would you call me on WhatsApp? This is my number. I thought, Jesus, I scarcely know what all this stuff is. It sounds like a DM on Twitter. It sounds like I'm sort of digitally mobile or something. And WhatsApp, now I've got a grandchild, we use WhatsApp all the time. So if anybody would like, I can show you a photo of my granddaughter. Much more fun. Where was I? And the Director General, so I call him on WhatsApp on Boxing Day, and he said, I'd like you to be my advisor on social determinants of health. And I thought, this is for show. It's pro forma. He just wants to be seen to be doing it. It's not serious. He said, come to Geneva and let's talk. So I went to Geneva. Last week, I was there. He has set up a new division of healthier populations with the Department of Social Determinants of Health. He said his mission was 3 billions, 1 billion more people covered by universal health coverage, 1 billion people covered by emergency preparedness, and 1 billion people with healthier lives. And to do that, he set up a new division. So I flew from Los Angeles to Geneva to talk about what this new division should be. And I said, you can't just deal with getting trans fats out of the food supply, which is what some people were saying. And important as the global framework on whatever on tobacco control is, you've got to deal with the structural drivers of inequalities in health, of economic inequalities, of climate change and environment, of colonialism and racism, as well as the conditions of daily life. So my being upbeat and optimistic is evidence-based. I digress. So this was our WHO Commission report, and we said on the cover, social injustice is killing on a grand scale. I wasn't entirely sure what I meant, but it seemed important to say it, because it was a statement, really, that we know what to do. to reduce inequalities in health globally, to reduce inequalities in health, 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 and to reduce inequalities in health within countries. It's not a mystery why people in the poorer part of Cheshire and Merseyside have worse health. It's not a mystery. It's not a scientific mystery. We know a great deal about why, and we know a great deal as to what to do. And that was the purpose of the WHO Commission, to bring that global evidence together. And in the wake of the Global Commission, I did the English review, and we will, we hope, on February 2020, the 10-year anniversary of the English review, publish a report, Marmot Review, 10 years on. What's happened? How are we doing? The answer is not terrific, not as well as one might have hoped. And then, as I mentioned earlier, the European Review of Social Determinants and the Health Divide. And on the 1st of October in Washington, D.C., during the Directing Council of the Pan American Health Organization, I will go to present the final report of our Commission on Equity and Health Inequalities in the Americas. And we've called it Just Societies, Health Equity and Dignified Lives. The animating notion behind it was that if we create the conditions for people to lead dignified lives, their health and well-being will improve and health inequities will diminish. I was asked, what would it take to be a Marmot city? That was my opening slide. That's what it would take. These were our 6 recommendations from my English review. Give every child the best start in life, education and lifelong learning, employment and working conditions, having enough money to live on. Parenthetically, I got interested. Some colleagues sent me a draft of a book which I read on universal basic services as an alternative to universal basic income. And I think we need further debate on this. People often ask me, what do I think about universal basic income? And I say, yeah, a really interesting idea. This idea is saying, no, we want universal basic services. We already know about healthcare. We take it as read that that's a universal basic service. Education is a universal basic service. What about having enough money to buy food? Food, surely, shelter, housing, etc. The 5th was healthy and sustainable places to live and work. And the 6th is taking a social determinants approach to prevention. Alcohol, smoking, diet, physical activity are all important, but they all follow the social gradient and they're all impacted by social determinants of health. So, the Lifecourse. Give every child the best start in life. Apologies to my King's Fund colleagues who've seen this slide before. We've been monitoring the percent of children with a good level of development, age 5. So look at the blue dots. The blue dots are the average. Each local authority classified by degree of deprivation. So up there, the least deprived, there the more deprived, and the more affluent the local authority, the higher the proportion of children age 5 with a good level of development. But there's scatter around the line. For a given level of deprivation, some local authorities are doing better than others. One strategy to reduce inequalities in early child development is to break the link between deprivation and poor child outcomes. And why am I showing early child development? Because it's key. Early child development predicts education. Education predicts what kind of job you'll have, how much money you have, how much control you have over your life, where you live, and the like. Look at the red dots. That's children eligible for free school meals. They're the poor kids. And this one really threw me. The poor kids are doing worse in rich areas. The slope of the line's the other way. They're doing better in poor areas. Look at this. So 60% of children age 5 have a good level of development nationally. 45% children eligible for free school meals. The gap is just under 16%. In Hackney, in East London, where my daughter lives, 65%, 61%. The gap's 4%. The poor kids in Hackney are doing as well as the English average. Now look at Bath and North East Somerset, lovely Georgian Bath. The average is not bad. Look how badly the poor kids are doing. My hypothesis, and I don't know if it's right, is in an area where there are very few poor children, it's really tough being a poor kid. In Hackney, where so many of the kids are poor, if you're not concentrating on the poor kids, what are you doing? Why are you getting out of bed in the morning? And they said to me, we tell ourselves every day, poverty is not destiny. We're in the business of breaking the link between deprivation and poor early child development. This is my evidence-based optimism. We can make a difference. And it's helped by the fact that the spending per pupil is higher in London than the rest of the country. When the politicians figured this out, they said, oh, we've got to have greater equity. We'll reduce the spending in London. No! No, increase the spending everywhere else. Generalize the London effect. The other side of early childhood, so there's the good side, what do kids get that's positive and nurturing, and the bad side is adverse child experiences. And each of these adverse child experiences in general follows the social gradient. The more deprived, the higher the frequency of incarceration, drug abuse, sexual abuse, and so on, alcohol abuse, domestic violence. And ACEs, adverse child experiences, have adverse consequences. Early sex, unintended teen pregnancy, smoking, binge drinking, all related to having 4 or more adverse child experiences. Violence perpetration. Half the perpetrators of domestic violence had 4 or more adverse child experiences. Violence victimization. Half the victims of domestic violence had 4 or more adverse child experiences. And in Scotland, I'm really pleased. They're really taking this on board. What can we do to address the problem of adverse child experiences? I think they're doing much more in Scotland and in Wales than we are in England. But the other side is child poverty. Great, break the link between child poverty and poor outcomes, but also do something about child poverty. Denmark, 9% of kids. Poverty is defined as having household income lower than 60% of the median. And in Denmark, Iceland, Norway, Finland, it's 9, 10, 11%. In the UK, 20%. And in the United States, 29%, just below Mexico. You could change that tomorrow. The Chancellor of the Exchequer could do more for health equity tomorrow by reducing child poverty, changing our fiscal policies. And when I talk about the social determinants of health behaviours, this is obesity prevalence in year 6 by deprivation, 2016, 2017, back in England. Most deprived, least deprived. Remarkable social gradient in year 6. And what's happened, the deprivation gap in obesity in year 6, going from 2006-7 to 2016-17, for the least deprived, obesity at this age hasn't changed. For the most deprived, it's continuing to rise. So the inequalities are getting bigger. Everyone's concerned about obesity. And I've said somewhat melodramatically, if you want to solve the obesity problem, you have to solve the inequality problem. Working age poverty. So our recommendation number 4, that really radical recommendation, everybody should have enough money to live on. What an idea. Well, it turns out they don't. This is people in poverty at working age, and that, whatever you call that colour, that pinky red colour, are the people in workless households where no adult is working. And these are the people in households where at least one adult is working. A majority of people in poverty are in households where at least one adult is working. They're not in poverty because they're lazy. That nice, cuddly editor of the Evening Standard, who, you know, what a nice, lovely, liberal man he is, the one who kept saying poor people have only got themselves to blame for their poverty. They're not in poverty because they're lazy. They're in poverty because they're poorly paid. And it relates to health in pretty dramatic ways. If people in England followed Public Health England's healthy eating advice, people in the bottom 10% of household income would spend 74% of their income on food. They can't do it. You can't blame them for not eating healthily, and that unhealthy food promotes obesity. Housing is a food issue. If you can't afford rent, you certainly can't afford to eat healthily. Housing is a food issue. We were talking about the council cuts. Margaret Whitehead and colleagues have been looking at this, looking at mortality for local authorities and the cut in local authority spending. Not suggesting a causal relationship, but it could be. But it's pretty clear that the more deprived the area, the steeper the cut, because the more deprived the area, the higher the mortality. I'm concerned about not running over time. I said that I think the mind is an important gateway, but it's not the only gateway. Air pollution and deprivation levels, the more deprived the area, the higher the deprivation. I said I really shouldn't read the newspaper, but there was I looking at the New York Times on the train, and President Trump, so California wants to keep its clean air standards. It's got an aim to have all new cars by, I think, 2025 to 52 miles per gallon. Trump is now taking legal action against California. He wants them to pollute. He wants to stop California having clean air standards. He'd like to go back to the smog of Los Angeles. And that's how we discovered that smog was bad for health. Well, we knew from the London smog. But the Los Angeles, that was coal dust. But Los Angeles, it was traffic and really damaging health. So California took action. And Trump's trying to stop them taking action. He wants dirty air. None of this clean air rubbish. Climate change, bring it on. I can tell you housing matters, which is what I skipped over. And conditions of household dwellings, proportion of children living in a household with one of leaky roof, damp walls or floor, or foundation, rotting window frames, door or floor. And if we look by country, so in Finland, they have very high housing standards. In Slovakia, in Sweden, Norway, Denmark. Here we are, another also-ran country. What sort of image do we have of ourselves? Why don't we want to be the best in health and the best in social conditions? Finland was a very poor country, but their image of themselves is they want to be the best in social conditions. They want to create the conditions for every Finnish child to lead a rich, meaningful, dignified life. And Finland always has the best measures on education of any European country, just behind the Chinese. So we don't do brilliantly on our housing standards, and that damages both physical and mental health. I said ensure a healthy standard of living. Martin Wolf, the chief economics correspondent for the Financial Times, great supporter of capitalism, published on the front of the Financial Times, I think yesterday or the day before, capitalism's not working, it's rigged. Rentier capitalism isn't working. And I heard him on the radio, he said, I'm a capitalist, I'm all in favor of capitalism, but the way we're doing it really isn't working. And this is part of it. Tax havens increase inequality. 50% of wealth in tax havens belong to the top 0.01% of people in advanced economies. That wealth is equivalent to 5% of global GDP. It's tax avoidance on a massive scale. And then added to that is avoidance of tax by multinationals. 600 billion euros a year shifted to the world's tax havens by multinationals. And Martin Wolf has got this documented in the Financial Times yesterday or the day before, of American multinationals, how much of their profit is in low-tax countries like the British protectorates in the Caribbean and the like, and how much of their profits are in high-tax regime. 7 times the amount of profit that's parked in low-tax regimes. They're avoiding tax on a massive scale. You remember when Starbucks and a couple of the other multinationals were brought before the Commons Public Accounts Committee, and they were asked, why don't you pay tax? And Starbucks said, because we don't make a profit in the UK. Ah, that's so sweet. Isn't that nice? Starbucks is making coffee for people in Britain, out of a charity. They're not making a profit. They're just doing it for us. Why don't they make a profit? Turns out they buy their coffee beans from the Netherlands. The Netherlands. Have you been to the Netherlands? They grow tulips in there. They have cows. They don't have coffee beans. Coffee beans come from Ethiopia and Costa Rica. They don't come from the Netherlands. What they grow in the Netherlands are accountants. So they have these transfer mechanisms within these big corporations to avoid tax. It deprives the EU of a fifth of corporate tax revenue, 60 billion euros. For the UK, 12.7 billion euros a year. And I said, compare that to 350 million pounds a week. I saw that on a bus somewhere. We really could fund the NHS if we stopped tax avoidance and stayed within the European Union. That would be a better thing altogether. So, Coventry is a Marmot city. And we're now working with them to try and evaluate what they've been doing. And I mentioned to colleagues just before we came in that when I was doing the English review, we went to Merseyside and was shown what the Merseyside Fire and Rescue Service was doing. And it was inspiring, and I talk about it and I write about it. In fact, somebody from Merseyside came down with a uniform and we had a photo together. But it's getting involved in youth programs, communities, on-site free gyms, gardening projects. Fantastic. And the West Midlands Fire Service took it on, supporting young people into employment and training. And working through the Lifecourse. This is from the West Midlands. It's terrific. The police, we've got the police. Talking to the police, they can be agents for healthier societies, not just knocking people over the head when they do something naughty, but being change agents for healthier societies. I was invited to Trieste. They told me it was an Italian Marmot city, so it was irresistible. I had to go. When I got there, I said, "Are you a Marmot city?" They said, "What?" Well, but they're doing it. They may not call themselves, I mean, the person who invited me said they were. They repeated the trick, and they got me to go to Bologna. And again, I asked, are you Marmot cities? But we'd never heard of it. But what they are doing, a bit like in Coventry, is actually working through all the major parts of the services in local government, in education, in healthcare, in social care, and the like. As you heard in the introduction, I spent a year as president of the World Medical Association, and I was trying to get the doctors involved. If we can get police involved and firefighters involved in improving health in populations, how about we get doctors involved in improving the health of populations? That's a radical idea. And I said, why did I tell you about my book? That the opening line was, why treat people and send them back to the conditions that made them sick? And I said my two messages to the doctors in a world of post-fact politics was evidence-based policy presented in a spirit of social justice. And I reminded them that we said on the cover of our WHO Commission report, social injustice is killing on a grand scale. And I said to the doctors, you should be agents for promoting social justice. That's what improving the health of communities and disadvantaged people is about. And I mentioned our PAHO Commission. I was in Washington, D.C., and I found myself wandering in the mall in the area devoted to Martin Luther King. And Martin Luther King said, I believe that unarmed truth and unconditional love will have the final word in reality. By the way, unarmed truth is a bit like evidence-based policy. Not quite as poetic, but evidence-based policy. And the spirit of social justice, well, Dr. King said unconditional love. I believe that unarmed truth and unconditional love will have the final word in reality. This is why right, temporarily defeated, is stronger than evil triumphant. There is a lot of bad things going on around us in politics and the like, but all of us striving to improve the health and well-being of our populations are on the side of right. Temporarily defeated, we will be stronger than evil triumph.